back to Other in First and 15. I'm glad to announce that today's guest is one of my friends, Christos, Professor Christos Georgalas from Greece. Good morning, Christos. How are you?
Hi, good afternoon, Puya. We are well, and we're thinking of you. We're thinking of everyone in Italy. We're glad that you are well, that you're back on your knees, and congratulations for your recovery.
Thank you so much. So today I've requested finally from Christos to talk about one of the benign tumors, which are very controversial in the rhinologic and rhinoneurosurgery field because of the treatment. Many reviews declare to one approach or the other. The issues has been debated. However, today Christos is going through this topic, and he will talk about osteoma of the sinuses and skull base and how to approach those kind of lesions. So please do remind to all the participants that question and answer are going to be able to be done at the end of his talk. There's a small icon that you should use for any kind of question, which is question and answer, but please do remind that questions should be done at the end of his talk. Please go ahead with your presentation.
Okay, thanks, Puya. Yeah, it's indeed, it's a great pleasure to be part of this course of this series of webinars. I think it's a great idea. Although, to be honest, it does feel a bit awkward giving a talk from home. I suppose the same for everyone. But it's one of the things we can do while we're staying at home and trying to prevent the growth and the spread of the COVID. So at least we can give some talks and we can listen to some talks. And we can stay social and stay engaged. So osteomata, the plural, and other fibrosis tumors is an interest of mine. It has been an interest for a few years. And there are many reasons for that. It's not only because of the surgical challenges that they present, and they do present often the surgical challenges, it's the questions they raise. And the questions they raise, I have written them here, is first of all, when to remove them? Do we need to remove them? How much of it do we need to be radical? How radical should we be? And what's the way to go around it? Do we know before we start if we'll be able to take it endoscopically? And do we know if we're going to need reconstruction? And we all talk about the osteomas, but in reality, there are three different histological subtypes of tumors which may look similar. And these are the fibrous dysplasias, the ossifying fibromas, and the osteomas. And you can see the table, and you can see it when it's recorded. I'm not going to go into detail, but it's important to differentiate between the monostotic and polyostotic fibrous dysplasias, because in the case of monostotic, a single isolated fibrous dysplasia, most of the times there's nothing that we need to do. In polyostotic, there are multiple cases, and that many times lead to deformity, and they usually appear in the maxilla rather than in the paranasal sinus, and they have a tendency to get malignant transformation. So that's something to keep in your mind about fibrous dysplasia. And most of the times it's something that doesn't grow very fast, doesn't need very aggressive treatment. That's not true for ossifying fibroma. Ossifying fibroma is different radiologically, and the difference is here. It has a sharp demarcation, has very clear margins that you can see on the CT, and I will show some examples. And in this case, one needs to take it out, especially the juvenile ossified subtype of the ossifying fibroma. The juvenile is a type of tumor that grows in younger, in adolescents, in younger patients, and it's more aggressive. And then, of course, the osteomas that we all know, but they still present in many cases a challenge. So I will not go, this is the one and last slide that will deal with general issues. I will go about cases and then talk apropos of these cases. So we have this, this patient, actually from Cyprus. She came with migraines, had no nasal symptoms, had, as these patients often do, she had a CT, and the CT had this image. You can see this lesion on the frontal sinus with heterogeneous borders, not well demarcated. We didn't know what it was. We did a biopsy, it confirmed the fibrous dysplasia. The headache improved and probably had nothing to do with that. And the CT hasn't changed after 4 years. There was nothing more to do. Similar story, 35-year-old cocaine user. Following trauma, he had a CT. And we see here, you can see the lesion on the pterygopalatine fossa. You can see the heterogeneous lesion. We took a biopsy. You can see on the video below, you can see here the biopsy going through a transpterygoid approach to take some of the tissue, which was osteotic, and it confirmed the fibrous dysplasia. Again, nothing malignant, nothing more to do, there has been no change. However, and one could argue, was there a need to do a biopsy in the previous cases? Why couldn't you say from the beginning it's fibrous dysplasia, it's a radiological diagnosis? Well, look at this case, which is much more recent. The two cases before were almost a decade earlier. Look at this case. What do you see? You have here on the clivus, on the pterygopalatine fossa, a diffuse area where the bone appears hyperostotic. The normal architecture is preserved. In other words, you have the normal contour of the clivus, of the pterygopalatine fossa. However, if you compare right and left, you will see there is a change in the, it's a typical, one could say it's typical of fibrous dysplasia. You preserve the contour of bone, there is no osteolytic lesion, no bone destruction. We took a biopsy. You can see it's part of the video here. Again, in the same way, transmaxillary, transpterygoid. We go in at the tissue, at the pterygopalatine fossa area, with cauterizing the artery, and then you can see we are entering, we are going to the Vidian area, the Vidian nerve, the Vidian canal. And because we want to take the bone, we don't want to drill it out. So I'm using the osteotomy to remove pieces of bone. And it's very thick. It looks somehow abnormal, but it's still very strong bone. And when it was removed, that was the result. It was an adenoid cystic carcinoma, which was quite extensive. It was taking all this area. It would have been impossible to diagnose without taking a biopsy, and indeed it did look by the way it looked at the CT, very much like a benign fibrous dysplasia kind of lesion. So things can always not appear to be what you think they will be. And another recent case, you can see it's from the last year, again, a 56-year-old female, multiple episodes of left sphenoiditis, and the lesion that's, you can see it's obstructing, you can go back. It is occupying the ethmoids, anterior ethmoids, posterior ethmoids. It's going up to the skull base and up to the lamina papyracea, but not invading intraorbitally or intracranially, but it does obstruct the ostium of the sphenoid. So it makes sense that this patient would get recurrent sphenoiditis. And in this case, one had to remove it. I don't want to go into a lot of details, but it involved some drilling. And then after the bone is thinned, it's become eggshell, then it can come out. You can see the pus here in the sphenoid. Once we enter the sphenoid, we can see there was a lot of pus there. But we need to remove the fibrous dysplasia completely. Otherwise, the risk is that the patient will keep on going. And you see some more pieces that are coming out. And at the end, this is the pre and post-op result, the CT before the surgery and the CT at the end of the surgery. And we're happy to get a complete removal. You can see it, sorry, you can see it here at this point. Why I'm saying this is because with these cases, what I want to illustrate is that, number one, fibrous dysplasia is not always obvious, and the diagnosis sometimes, despite all our progress that we have on a CT and MRI, needs to be confirmed by histology, sometimes, not always. And number two, in many cases, you can leave it alone. It doesn't need any treatment. It doesn't cause symptoms. But in some cases, when it obstructs the natural osteo of a sinus, it can cause complications in terms of obstructing mucus, causing secondary, and this is a very similar case, but I'm not going to go into more. It can obstruct the ostium, it can cause sinusitis, and then it needs to be removed. And another female case, female patient, another tumor that looks very similar. Now, in this case, you can see that it was invading. You can see how the contour of the orbit on the right side has become concave, and it seems to be growing intraorbitally, but still preserving the normal architecture. And this was a lady who had symptoms from her eyes. She had diplopia and she had a mild proptosis. In this case, taking the borders, going anterior to the tumor meant doing a draft to A, opening the frontal sinus anterior to the tumor, as you can see here. I'm using a Kerrison to do a draft to B essentially, and then I'm pushing on the tumor. I'm at the anterior border of the tumor, as you can see it here. And as we progress and take out the consistency, the center, the core of the tumor, we can try to to delineate the borders. And we're going towards the most posterior part of it, the posterior border of the tumor, and then entering the sphenoid. Now the frontal is the anterior limit, the sphenoid will be the posterior limit. And by making sure that we have these two limits of the tumor, you can see it here on the navigation, is very useful in these cases. Then we can keep on and take the skull base from posteriorly to anteriorly and make sure that we get a complete excision. The part that we are always worried about, of course, the part of the lamina. And you can see here, I'm pushing a bit on the eye. We can see that we have taken out all of the bone that is adherent to the lamina papyracea. We can take out the remnants here. And we know we have removed it. Once we push on the eye, and we see there is no bone left. Finally, the medial part, the tumor. And just for the final issues. There, you see we're pressing on the eye and we can see that there is movement, which means that the bone has been removed, that it was pushed on the eye. And this is the outcome, the result. I was going to do a post-op CT just to confirm that the removal was complete. Some of these tumors will grow, especially the ones that we remove are the bigger ones, which will tend to grow. And this is the post-op result. On the left side, you can see the complete removal of the tumor with preservation of the eye. So these were my personal experience. This is my personal experience with fibrous dysplasia. I have seen 15 patients, but not all of them needed surgery. And this is a very different story. These are younger patients. This is the Ossifying fibroma. Now, I'm not going to go into a lot of details about this, but what is important about the Ossifying fibroma is that it's an aggressive variant. It's very different from fibrous dysplasia because it presents at an earlier stage. It can recur, it can invade the orbit, and there's a very characteristic image on the CT and on the MRI. You can see it here. So you have this multiloculated lesion that you can see here with multiple cystic components within the tumor and a very well-defined border on the CT, while on the MRI, it appears much less hyperostotic than fibrous dysplasia or even less than an osteoma. And this is after the removal. And of course, there is an issue. There is a case for using biphosphonates. One cannot remove this, or pamidronate infusions in children, which can lead to stabilization, not necessarily the complete disappearance of the tumor, but stabilization, reduction in size. And again, my experience with 3 ossifying fibromas. But I think the most interesting part are the osteomas, which is what most of us will have to deal with. And now, traditionally, there have been a lot of discussion, there was a lot of controversy about whether one should use the endoscopes for the osteomas, especially in the frontal sinus. And typical contraindications include osteomas that go into the brain, that go into the orbit, that go laterally beyond lamina papyracea, extend laterally into the orbit, if they go high into the frontal sinus, or if they go anteriorly. Let's look at this example. Again, a very recent patient, was actually from 2019. And this patient presented with left-sided headache. And you can see here, he had this tumor, this clear osteoma that was above the orbit on the left side. Now, what was interesting is that it was clearly, as you can see, it was going clearly lateral to lamina papyracea, to the lamina papyracea, it was extending far more laterally. Also, it was attached on the roof of the orbit, and it seemed to be merging with the posterior and lateral wall of the frontal sinus here in this area. This was the area of attachment. So it wasn't the size of the tumor. There was no intracranial extension. It was a clearly laterally attached tumor. So would someone want to remove it via external osteoplastic approach or via transnasal approach? To be honest, there is a good argument for both. This is the sagittal view to have a better look. And you can see again the attachment anteriorly and posteriorly, and you can see how it completely fills the lateral part of the frontal sinus. You can see it there. So definitely one, in my opinion at least, someone should not try the Lynch-Howard incision for such cases. It leads a very bad cosmetic result. One could argue for an endoscopic approach or for an osteoplastic. Now, when I want to think if I can be able to remove it, I draw an imaginary line. You can see it here. I want to draw a line and see if I can reach with my instruments. This is the line, working through the nose, the most lateral extent and the most lower lateral attachment of the tumor. Now, as you can see, people have been talking a lot about the anteroposterior distance, but what I find much more important is the lateral, the intercanthal distance, the space you have here between the one orbit and the other orbit. All this distance, the intercanthal, interorbital distance, to a large extent defines the amount of lateral access you will get. And there was more than enough, so I decided to go endoscopically. And I'm starting in these cases, this is a typical case that I would use an inside-out technique because I want to go from the center of my field towards the osteoma, not to the natural osteum. Here, I'm working on the right side. I'm using otological instruments, and I like to use otological instruments for such cases to take the flap. So just to go a bit back. So that's the right nasal cavity. And what I'm doing is I'm using the monopolar diathermy to create the laterally based nasal flap. That's the flap, I think, that was initially described by Castelnuovo's team, and Dr. Al-Katani was one of, together, of course, with Paolo Battaglia and Alkis and Mario Trujanoni were also authors in that paper, but it was initially described by Castelnuovo's team, and it is a laterally based flap that we can use later to make sure that we don't get stenosis of the osteum. So laterally based flap means it goes onto the nasal septum and laterally just anterior to the attachment of the middle turbinate. I'm using an otological instrument to dissect the mucosa, and as I'm going towards the roof of the nose, we're finding the ethmoid branches of the anterior ethmoid branches, the septal branches, and then behind this, the first olfactory fibers, which will take us to the frontal sinus, will take us to the posterior limit of our frontal sinus drilling that you can see here. So I'm entering the frontal sinus, and in this way I can be oncologically safe as I'm not entering through the osteoma, I'm entering laterally. You can see it here in this navigation image, lateral to the osteoma, and then I can start my drilling. What I'm using is a 70-degree diamond, rough diamond drill, and I'm keep on drilling above the orbit. I have enough space between the orbits to use my curved instruments to the size. I'm taking the last part of the osteoma above the orbit on the left side, and you can see the wide frontal sinus, what kind of access it gives me. And the nice thing with the osteomas is that once you manage to debulk the center of the osteoma, you can always take the shell in one piece. It doesn't infiltrate, in other words, it doesn't invade the bone. The mucosa is healthy on both sides, so it creates a buffer between the normal bone and your tumor. And the final parts, the hardest parts, and then taking down the flap, pushing down the flap. This is the post-op view. And you can see that the cavity is open. And again, I want to have always an ICT to confirm. And well, I don't have it here, but I can show you the CT, which was completely clear. And in that case, the osteoma went endoscopically. Does this work always? Of course, no, it doesn't. When, in this case, in this patient, you can see already from the photograph that he has a deformity here on the right forehead. There is a swelling, which means that the osteoma has breached the anterior frontal sinus wall. You can see it, of course, on the CT scan. And it has also breached the superior orbital wall. Now, in such cases, it's not that you wouldn't try to do it endoscopically. It is that in any case, you would need to reconstruct the anterior wall. So you would need to do an external approach, even if just for the reconstruction. So in such cases, it doesn't make, in my mind at least, any sense to try endoscopically. And indeed, I did a typical osteoplastic approach. I find very helpful for the osteoplastic approaches. In the past, we used the CT and the measurements on the CT, and you can still use it, or you can use a simple X-ray from a distance, you know, so that it's straight and it doesn't change the size. But I find using the navigation, you can see it here, using the navigation directly intraoperatively gives me a better feeling for how to raise the flap. And you can see here how the osteoma looks from an external approach. And after drilling it, the last part is always, again, like endoscopically externally, it's easy to remove because as you can see, it is covered, it looks a bit like a brain here, funny enough, but it's covered on normal mucosa, and the mucosa produces mucus and creates a buffer, creates space between the dura. In this case, the dura was exposed. But again, that was not a problem because the dura in itself would not get infiltrated or invaded by the osteoma. There will always be a buffer. The dura will be intact. And then you do not need to reconstruct, provided there hasn't been any breach of the dura. The dura in itself is more than enough to prevent any episode of sinusitis, of meningitis. And this is the post-op view with the reconstruction using some titanium plates. And cosmetically, the patient was satisfied, was happy. But of course, remember always, osteoplastic flap doesn't mean doing a gallowing incision. I don't think there is any role for incisions that go just above the eyebrows. One should always aim for an incision high in the hairline. It takes a bit more dissecting, but the cosmetic result is much, much better. So, to come towards the end, watchful waiting or removal. As I said, in many cases, there is no need to take fibrosis tumors out. When do you take them out? Number one, if you have a diagnostic dilemma, you saw earlier that was an adenocystic carcinoma, and one thing it was an ossifying fibroma or a fibrous dysplasia. Number two, when they cause symptoms. The symptoms they cause are directly related to their location. So either they can obstruct a sinus. With sinus, they can obstruct the sphenoid sinus and they cause sphenoiditis or even meningitis. They can obstruct the frontal sinus and cause a mucosal. In these cases, they should be removed. They should be removed when they cause deformity, when they come under the skin and you can see a bump under your forehead, or when they push on the eye and you can get diplopia or you can get exophthalmos. And when you see that the osteoma, even if it hasn't caused the complication, is about to cause them, it has blocked the frontal sinus, so it's a matter of time before you get the mucosal or the meningitis. So that's when you remove them. This is my personal series, 25 patients in total operated. And when should one not try to take them through the endoscope? I'm going to go a bit through the literature, what has been written about this. And people have said, if it's an intracranial extension, if, in other words, it has eroded the posterior wall of the frontal sinus. Well, I don't agree, personally. I think that, as I showed in the osteoplastic plaque, but also endoscopically, if the dura is intact and you can remove the tumor either endonasal or externally, but the dura is intact, you don't need to reconstruct. And again, we deal endoscopically with tumors with extensive intracranial extension. In itself, the extension intracranially is not a contraindication, not anymore. What about orbital extension? Again, orbital extension posteriorly can be dealt with very nice and very elegantly endoscopically. Anterior orbital extension, anteriorly meaning anteriorly to the nasolacrimal duct, of course presents an insurmountable problem to deal endoscopically. You don't rotate the endoscope against 360 degrees, but in this case, you may need a transconjunctival incision, so you can deal with the most anterior part of the, like in this case, like in this tumor, most anterior part of the osteoma, of course. What about lateral extension? I showed you earlier the osteomas that go laterally beyond lamina papyracea. And as I said, what I think is after a complete trap-free, it's not the anteroposterior, but you want the lateral distance. You can see here as opposed to here. The more lateral distance you have between the two orbits, the more space you can have to go laterally and go and remove the most lateral inferior extensions of the osteoma. As I said, usually the issue will be the lower lateral frontal sinus, but that depends. And what about the superior high attachment to the frontal sinus? That's not a contraindication. The size of an osteoma takes some time. What about the anterior extension? Anterior extension is always an absolute contraindication, because even if you could turn your endoscope against itself, in other words, you could with the endoscope drill under the skin, it wouldn't make any sense, as you would have to open in order to reconstruct. So this is part of my, I did with Dr. Goudakos, we did a review and looked at the different publications and the different suggestions, including by Chi, which made a classification a few years ago. And according to his classifications, which osteomas should be dealt with endoscopically. And my feeling is that the current, and that was now, it's already a few years late, but I don't think these things have changed so much, that I think that actual contraindications endoscopic approach is anterior extension, tumors with anterior table erosion and anterior to the nasolacrimal duct. Orbital or intracranial extension is not a limitation, and very large tumors with a big attachment is a relative limitation related to the time and the time that it may take to drill them. And sometimes they may need to be staged, even in two cases. This was the actual paper. And currently, we are working at the Athens Neuroanatomy Lab with two colleagues, a neurosurgeon and an ENT, Dr. Papatsoutis and Dr. Kalivas, on actually doing a cadaveric study, and we're trying to define the limits of working laterally with the drug-free, and what are the limits that can predict before you operate on the basis of the CT of the lateral, most lateral access you can have that you can provide it by a drug-free in terms of lateral tumors. Summarize, think of the need for a two-stage surgery. Think of the instruments that you have and the experience that you have before you operate. Osteoplastic flaps is a very good approach, a very useful approach, and there is nothing wrong with happening. And there is very limited role for, of course, for least half of the galvanic incision. Thank you very much.
Christos, for your presentation. We have some questions, as already said. You have people want to ask questions. Please do use the question and answer topic and section. There's few things that I would like to address myself and then from the audience. The first one is that how would you address any registrar or any fellow that would like to approach for osteomas, like the example for an ethmoidal osteoma? Would you recommend a learning curve before approaching to such cases? Would you like to address the people that would like to approach to extensive lesions, to have in mind a flow chart or something like that before approaching to such lesions?
It's a very good point. It's a very, very good point. I think it's two things. One thing is anatomy, and the second thing is being confident with using a drill. As I heard Professor Castelnuovo said, and I couldn't agree more, I think that probably the best stage in a surgeon's career in terms of his age, probably 35 to 45. So it's completely nothing against young surgeons dealing and doing complicated cases. On the contrary, I think in many ways they can be more precise and more competent than older surgeons. However, having said that, it takes some time to get used to using the drill. And it's like when you do mastoids, you can start by doing a cortical mastoid before getting and going to more complicated ear surgery. In the same way, it makes sense to start with a small ethmoid osteoma, like 4 or 5 millimeters, that you can often find while doing a fez, and remove it before having to do with much bigger osteomas. And the second is anatomy. Using a navigation can be very helpful for confirming when you are going to a lot of courses. There's a learning curve. Spending time, as you did, with people and in centers of excellence, where you can see people operate and you can get some feedback. But I see nothing wrong with people operate as long as they have the, how can I say this, as long as they have the interest to get involved and the interest to spend time and devote time to become good in that, then anyone could do this.
So here's a point, and I like the statement that you said. It doesn't mean ages. It's important to have priorities and a recognition that dissection courses are essential to get into the field before approaching to such cases. Like behavior should be compared to anatomy knowledge, and also have the equipment, which is basically very important, because equipment, as one of your last slides reported, if you change the drill, velocity will affect also vital structure. So we have to keep in mind that's very important. So let's start with the questions. The first one is coming from the Zoom application, then we will have other questions coming from Facebook and YouTube. The first is how to identify important structure like skull base lamina papyracea.
Okay, two things. One is you try to start, so you come from the borders of the lesion. Again, like in oncological surgery, you try to identify the intact anatomical landmarks. Like when I showed earlier, I had the fibrous dysplasia. I wanted to go anteriorly and find the frontal sinus. Posteriorly, I found the sphenoid. And then having the anterior and the posterior part of the lesion, I would bring them together and I knew where the skull base would be. Equally, to identify the lamina papyracea, I could go and do a wide antrostomy. By doing the wide antrostomy, I could find the floor of the orbit and then follow it medially and then superiorly. That would lead me to the medial wall of the orbit. In other words, one way to keep in mind is to start from the obvious, visible, untouched landmark, and then step by step move towards the landmarks that have been obscured by the tumor. Number two is the navigation is very important. And I must say that when you have a tumor that goes all the way up to the lamina papyracea or to the skull base, sometimes it's impossible to know where the tumor ends and the skull base begins, so the navigation is helpful. And number three, can you hear me? Yes, number three, so I said number one is finding the landmarks and getting between them, going like finding points and getting from one point to the next, one dot to the next with straight lines. Sphenoid, frontal, skull base in between. Number two is the navigation. Number three is be very sensitive to very subtle, very small changes in the color and the consistency of the tumor. Especially in the osteomas or fibrosis tumors, when you drill, you can feel the difference between the bone of the osteoma, which is much harder, for example, the cortical bone around the osteoma, and the bone of the skull base, which somehow is more spongiotic, more softer. But one must be very, very acutely aware of the subtle changes he will find in color and consistency. So these three things.
I think that you and somehow explained the second question as the professor in case of asymptomatic big fibrous dysplasia, for example, invading multiple sinuses, orbital, medial wall, skull base. So you go for total removal or just decompression of vital structures?
Yes, well, if one can do a total removal safely, then one should, of course, aim for a total removal. Now, the reasons he may not be able to do the total removal is either because A, it is not possible to be done, or B, it's not possible to be done by him. And there is a subtle difference between the two cases. In some cases, it's true. For example, you have a fibrous dysplasia, which completely encases the carotid or the optic nerve in a patient who is otherwise asymptomatic or has very little symptoms and no visual loss, right? It has been shown, there was a meta-analysis, it doesn't make any sense to try to decompress preventively the optic nerve. The outcomes, the visual outcomes are much worse than if you leave the optic nerve on its own without removing the tumor around it, provided that the visual acuity is normal. On the other hand, it's a different story if you already have some visual loss, in which you must remove. So in such cases, you don't remove it. On the other hand, if you have a tumor, a fibrous dysplasia that borders on lamina papyracea like I showed and on the skull base, then of course you can go around it and leave the skull base and the dura intact and leave the periorbita intact, and no harm is done. And you have removed it without causing any damage. In such cases, I think it goes without saying you should aim for complete removal.
Another question from Facebook. The colleagues is asking, what do you suggest for postoperative medications?
To be honest, these are patients who most of the times don't have any inflammatory issues. So the whole thing with postoperative medication is just to help heal the cavity. What I advise them is to do a lot of rinsing, and a lot means 7-8 times a day with 250 ml of normal saline every time. And I give them, although maybe it's not necessary, but I advise them to also use topical steroids within the rinsing fluid. Usually I ask them to use Pulmicort, 0.5 milligrams, in the first and the last rinsing of the day. And in between, just to rinse with normal saline. I gave them some ointment just for the nasal ointment to avoid the drying of the nose. And I see them if it's a drug-free at 2 weeks, and I remove the small silastic splint that I have put in the frontal sinus.
Let's go back to other question from the audience from the application, and his colleague is asking how to follow up these tumors in percentage of recurrence.
How do I follow them up? I usually do, I want to do a CT or an MRI the first postoperative days for 2 reasons. One is to confirm that it has been completely removed, and secondly is to, in case of tumors which abut the skull base, to exclude the possibility of an intracranial complication. So I have an early post-op imaging from the first week, the first days after the surgery. And then I usually will do 1 CT at about 6 months to 1 year after the surgery. If it shows complete removal, I don't normally follow up with further imaging. If there has been a remnant, then I will do another imaging after a year. And then depending on the rate of growth, maybe we'll repeat it or leave it for 3 or 5 years later. It depends. But in case of complete removal, you don't expect this to come back in case of osteomas.
There's another question from YouTube. This colleagues from the United States is asking if you have cases of osteoma of the floor of the maxillary sinus, would you approach it through an external approach like a Caldwell loop procedure, or would you go endoscopically?
It depends. It depends. On the floor, again, you see, it's very similar question. What I said about the frontal sinus, how lateral it is, how lateral we can go, depends on the size, the distance between the eyes, right? This will give me the angle. The maxillary sinus, the floor, sometimes it can be at the level of the nasal cavity, or it might go down below that. So when you operate from the nose, you may find that you have the floor of the maxillary sinus at the level of the floor of your nose, or you may find that it's 1 or even 2 centimeters below that. And the anatomical situation will decide which way you will approach it. In most cases, I would go endonasally. I would say I will try to go endonasally. In some cases, I may do a medial maxillectomy, again, as described by Castelnuovo, an extended even one if it's very laterally, going up to the infraorbital nerve. But very, very rarely an external approach, Caldwell-Luck.
I think that this is a statement that I would like to express. It's the new instrumentation, the possibility to use curved instruments, curved drills, or at least expand our procedure through equipment was completely changed our field, and the percentage of the endoscopic procedures, highest number of them has been done endoscopically. Do you think that this is just because of we would like to achieve that, or this is just because we can do it?
Yes.
So
a good question, but to be honest, okay, I can say for osteomas, in some cases, what I said, the contraindications, right? In cases of very big osteomas, one could argue that rather than subjecting the patient to 2 procedures, if you want to stage it, then it would be much easier to do it in one by an osteoclastic flap. And I must say the osteoclastic flap approach is a really, really non-traumatic, very easy to recover from operation. The patients don't get any trouble with that. On the other hand, if we're talking about lateral rhinotomies or Lynch Howarth, or we're talking about the incisions, the facial incisions, a lot of patients nowadays, they really want to avoid them. They look bad. It is a problem. We see that there is a big industry in aesthetic surgery. People will go to huge lengths just to change the way their nose look, or to use fillables or Botox or whatever. And you can realize how important for a lot of people is the way they look, the cosmesis. And I don't think it's fair to deny them the option of avoiding a scar in the face from one place if they can avoid it, right? However, osteoclastic flap doesn't leave a scar, essentially scarless, because it goes in the hairline. So that's a valid approach for many cases. One should think hard whether he would want to do it endoscopically or via an osteoclastic flap. It's not always the best way. The fact that you can do something doesn't necessarily mean, as you said, that you have to do it. Think how comfortable you are with that, how long it will take you, and what risks you are taking with the patients before you decide.
Exactly, this is exactly this point. Sometimes cosmetics and stuff like that should be very discussed prior to surgery, and also the surgeon should decide what do his best and what he can do or she can do for the best of the patient. We unfortunately don't have much time to that. I always tell our audience that I will provide your credential or email for further questions. We do have it. Some of them I'm reading it. Could not be answered right now. First, because of conflict of interest, and because some of them are also asking about navigation system and stuff like that. So if you don't mind, I would like to be able to provide your email or whatever you want. Yes. So this will be able to let them be in contact with you. Thank you, Christos, for your brilliant presentation. I would remind everyone, please stay online for the next topic, which is going to be May 1st, Friday, with Zara Potter. She's going to talk about therapeutic options for treating patients with olfactory loss. By the way, this was done many months ago. I finally made the whole guests before December, so this wasn't done on purpose. It just happened. And so Zara will talk about what's going on also in this COVID-19 pandemic.
Yes.
By the way, I would like also to remind Christos the next year, if I'm not wrong, there are going to be one big appointment in Greece because you will be the president of one of the meeting that are going to be next year. Am I wrong? Or going to be in 2 years?
The 2 years. It will be in 2 years. It will be the not in Greece. Together with Wouter van Furth, we're organizing the Endo Amsterdam, which will take place. We'll see. Things are very now complicated in terms of as you know, the situation. But yes, we're organizing with Wouter van Furth the Endo Amsterdam in 2022 and hopefully in April. But let's be sure that everyone is safe until then, that everyone is healthy, and we have plenty of time for congresses. I think the important thing is for everyone to do his best, her best, and be safe for the next few months.
Thank you, and please do remind that everything will be able to be joined or watched again on our YouTube channel. Thank you, Christos, for being with us today, and I hope to see you very soon or in the future, not in person, but also online. Thank you.
Thanks, Puya.
Ciao, ciao.
Well, bye-bye.